Is online. We're just waiting on the department. They did tender an apology that there will be a few minutes late, unfortunately, due to circumstances beyond their control. So just a bit of patience, please. Thank you, member. Thank you very much. Good morning, honorable members. Good morning to Dr. Moodley, who's representing the Department of Health and Wellness this morning. And good morning to our procedural staff and support. Today is Friday, the 5th of August, and my sincere apologies that we are running a bit late due to circumstances beyond our control this morning. Therefore, all members in person as well as online and all our guests that may be following the proceedings via YouTube, you are most welcome to the Standing Committee on Health this morning. At this stage, I will ask members for the record to kindly introduce themselves. My name is Wendy Kaiser-Philander, and I'm chairing the Standing Committee of Health.
Good morning, Chairperson and everyone. My name is Rachel Van Vossel, and I'm a member of the Standing Committee.
Good morning, Chairperson, all the members. My name is Dan Platt. Thank you.
Thank you very much, members in the committee room, members online.
Good morning, Chairperson, and to the committee, the department. My name is Ayanda Barnes.
Thank you very much, Member Barnes. The only apology received this morning is that of Member Baku Foss. No other apologies, Ms. Jamke?
No apology.
We note.
No apology, Chair. I did not receive any apology from the EFF.
Thank you very much. We then duly note Member Baku Foss apology, and then I will ask that the departmental representative kindly introduce himself for the record.
Good morning, honourable members that are present here today and online. My name is Dr. Melvin Moodley. I am a representative of the Western Cape Department of Health and Wellness.
Thank you very much, Doctor, and you are most welcome at our committee meeting this morning. Dr. Moodley will then now proceed to brief the committee on the progression of the COVID-19 pandemic and the progress of the vaccine rollout in the province. As members also duly note that the COVID-19 ad hoc committee were dissolved, and all portfolios are now from time to time will be asking the department to give us an update on the status of COVID-19 within the Western Cape. Dr. Moodley, without further ado, the floor is yours to kindly present to us, after which members will then have the opportunity to interrogate your presentation and to ask some questions for clarity. And the committee afterwards will then also embark on recommendations and resolutions that we will put forward to the department. Thank you very much, Doctor. You may proceed.
Thank you, Member Philander and Honourable Member Philander, and thank you, colleagues. And first of all, the Department of Health and Wellness would like to thank everyone for the invitation today. It's a pleasure to be speaking to you to talk about the COVID-19 and our vaccination program in the Western Cape. So we're going to do two presentations today. We're going to start first with the COVID-19 update, just to get an idea of what's going on and where we are. I hope to be able to give you the latest hot of the press news so you are fully informed of what is going on in this particular space. But let us start with the first and perhaps the most sad piece of information about COVID-19, which is that the World Health Organization estimates that the excess mortality from COVID-19 from 1st January 2020 to 31st January 2022, that's worldwide. This is an estimation, but the estimate is 14.9 million. So about 15 million people are estimated to have died from COVID-19 worldwide. That is a massive amount of people. It's close to the number of people, depending on the estimates you read, that died from World War I. So a huge global tragedy. Now, let's move to this graph. And this graph is about the COVID waves. And I think we're all familiar with it. We know about wave 1, wave 2, and we get a sense of what it is. But before we start, just a little bit of background information. So on December 1st, on 31st December 2019, the international community received the first notification that someone had an unexplained respiratory disease in Wuhan in China. And that was the start of the COVID-19 era as we've known it over the next 2 years, something that has completely changed every one of our lives, whether it's a work aspect, whether it's a personal aspect, whether it's a family aspect. And thus we see these waves that have occurred in the Western Cape. Now, this is a graph of the Western Cape, but it is very similar for the rest of the country. So I'll take you through this graph because it's very interesting, right? So the first, each line has a different color, and we've keyed it so you know what it is. So we'll start with the gray lines, the bars, the Manhattans. Those are the actual COVID-19 diagnosis. So the COVID-19, the new diagnoses. The blue line, this line here, is the patients in hospital from COVID-19. The thick red line are the deaths by date. So these are the people that have died from COVID-19. Now here's an interesting one. The green line is oxygen consumption. And what we found while we were learning about COVID-19, because so much of it was about learning, we found that if we measured how much oxygen we were using in our hospitals, we could actually measure how severe the COVID waves were. And if you look at it, the green line, the oxygen utilization tracks exactly in the first 3 waves with what was happening with the pandemic in the Western Cape. Now, I'm going to show you a few interesting things. Here you see wave 1. You can see that the gray lines, and you can see that wave 1 was quite severe. Wave 1 was certainly more severe than wave 2. You can see a much higher peak, although not as wide as wave 1. And then wave 3, which was as high but wider than wave 2. So those are the first 3 waves. And if you look at it, if you look at the deaths, the thick red line, they seem to go along with the cases. So the more cases you had, the more deaths you had. Happened in wave 3 as well. Then something strange happened in wave 4. And this was the Omicron wave, which was in December 2021. Look at how high Omicron got. It went really high in terms of the peak, but the deaths seem to be proportionately lower. And we refer to that as the decoupling. What that means is that we're having a lot of cases, but not that many deaths. Now, the immediate question is why? Why is it? So there are a number of factors. One, it's the virus itself. And the question of whether Omicron is less severe. And there's certainly scientific evidence to show that Omicron is slightly less severe than some of the other variants that we've had. So that's the first part. The second part, though, is that we have now achieved a level of protection. And that protection is because of vaccinations or previous infection. So if you get infection, you get a degree of protection. So it's both, right? And together, the decreased virulence and the previous, the existing protection combined to make this virus, combined to result in the decoupling of the cases versus the deaths. And then if you look at this the fifth one, where we see a resurgence in the number of cases, you see that the red line is almost flat. So there still are a few deaths, but much less than was occurring in previous waves. And this occurred in the May-June period of this year. If you're interested, and you can look at the data, but I will provide the updated slides. This covers the number of days for wave 1, wave 2, wave 3, and wave 4. And you can see the dates that it occurred, when it peaked, etc. So you can see that wave 1 was 106 days, wave 2, 92 days, wave 3, 120 days, and wave 4, 64 days. Useful information to have and to understand. Now, the next question is, that's nice, but where are we today? What is happening with COVID-19? If you go around, the malls are full, and that's a good thing. Commerce is returning to normal. People need jobs, right? Buses are full, taxis are full. We've moved away from the COVID regulation. So where are we in the Western Cape with this? If you look at it, this was the May-June increase. You can see that graph going up, and then it's gone right down. And this is one thing you want to be performing really low in, the number of COVID cases. So if you look at it, there's been a severe drop in COVID-19 cases. Now, the one thing to understand, though, is that that might be because people are testing less. People get sick and they say, well, not feeling too bad, I'm not going to go get tested. So we use other measures not dependent on patient behavior to determine whether things are actually going. And when we look at the other measures, they are showing that things have gotten really low. They match the drop in cases. So if we look at the bottom, the middle, it's the admissions. And there's been a 9% drop since last week, and it is really very low, almost flat. If you look at the deaths, we're having about 1 death per day. Now that's still 1 death per day, and let's not dismiss that, but it is significantly lower than the number of deaths we were having in the previous waves and certainly at the peaks of waves. There's also something interesting called proportion positive. This is the number of positive tests we get when we do tests. So let's say we do 10 tests, how many of them are positive? The higher the number, it means the higher or the more significant we are in terms of COVID-19. At the peak of the most previous resurgence, if we did 10 tests, sorry, I'm skipping. If we did 10 tests, 4 would come back positive. You may have in your personal lives noticed that everyone was testing and everyone was coming back positive. Now no one is coming back positive. And right now it's 10%. So if 10 people go get tested, 1 person is coming back positive. Right. Let's break it down into the various geographic areas in the Western Cape. Sorry, I'm just having a slide. There we go. And this is the metro, and these are the health sub-districts in the metro. And whether it's in Eastern, Tygerberg, or Khayelitsha, the numbers are going down similarly across the Western Cape. And if we go to the rural districts, whether it's the Central Karoo or the Overberg or the Garden Route, then the patterns follow the same. We have had decreased cases. We had one of our lowest levels, decreased deaths and decreased hospital admissions. Now we're going to get a little bit fancy, right? I'm going to turn you into epidemiologists. Now, this is what COVID has done, right? We've all become scientists. We are looking at graphs. We are talking about virulence. We're talking about variants. I get regular phone calls from my brother asking me about reproductive rates and new medication. So this is what COVID has done. And I'm going to show you something. We're going to talk about something called reproduction number. Now, a reproduction number is how fast the virus can be transmitted. So if you have a reproductive number of 1, it means if I get sick, I pass it on to 1 other person. If we have a reproductive number of 2, and there are times when we've reached 2, it means if I get sick, I pass it on to 2 people. Those 2 people pass it on to 4 people, and it grows exponentially. It means that if your reproductive number is below 1, then the number of cases will decrease over time until they get to a very low baseline. At the moment, if you look at this green circle, our reproductive number is below 1, right? So we are on a downward trend. There was a little bit of a bump in this week of mid-July, and we're not really sure why that happened. It may be because schools opened again after holidays, public schools, and so we had increased cases. No way to be absolutely certain about that, but that's reproductive number. Okay. Then one more method. Remember I told you that doing cases is not the best way of knowing if people don't get tested. So we do something called wastewater sampling. So we actually look at sewage. Scientists are strange people. They'll look for evidence anywhere, right? So how it works is this. If you are sick with COVID, in your stool, there's protein from the COVID. And so if we test sewage, public sewage, general sewage, we look at the amount of those particles and we can tell whether we're getting a wave increase. So it's actually quite fascinating. And if you look at it, these graphs are quite complicated, but the latest data is as follows. This is from 18 July. We're waiting for an update. We are just slightly above the lowest level of concern in 14 of 24 plants in Cape Town, 1 out of 3 in Overstrand, and 1 out of 4 in Breda Valley. But the message is this. The levels are generally low, and we're not too concerned about any increases at the moment from wastewater. So all our objective data seems to be showing that things are going okay. Now we're going to talk about something brand new. This information was available last week, and it is information on variants. So they found we did genetic studies, and we found samples where there was a slight difference in the variants. At the moment, now we all know there was Delta, there was Omicron, and then within Omicron there were slight differences. I'll show you the differences. But last week we saw a virus, and it had 8 pieces that were slightly different from the others. Now, does this mean this is a new variant? What does it all mean? We're still studying it at the moment, so we will send out that information as soon as we have it available. We're not overly concerned. We think it will behave very similarly to Omicron, and that our protection from vaccination and previous infection will remain. But I'm giving you information that's hot off the press. If we look at the variants to date, the different colors imply different things. Now, if you look at it, the orange, so the blue, let's do blue first. The blue is Delta. That was the third wave that we had. The first wave was alpha, the second wave was beta, the third wave was Delta. Then Omicron is the orange. And you can see that it's almost like these social media apps. When a new one comes, people forget about the old one almost immediately. So poor Delta got wiped out by Omicron. And then Omicron had its own subvariant. So B2 is the red one. B2 took over. And at the moment in South Africa, the orange is B4 and the yellow is B5. So that's the variants that we have in South Africa at the moment. They're the fastest spreading. But as I've said before, we have a lot of pre-existing protection against it. Right. This is the one this is a really interesting graph, and it speaks to something we call excess deaths. And we do excess deaths in South Africa as well. Now, if you think about it, how do we know whether someone has died from COVID-19? We need 2 things. We need to have them tested, and we need to know that they died. We need to know that they died. So if a person anywhere in the world doesn't get tested and dies, but they had COVID-19 and we don't know that, then we technically don't know that they died from COVID-19. So what the scientists do, the clever scientists, they do something called excess deaths. They look at all the deaths and they ask themselves, why should we have more deaths now than any other time? Is there something accounting for it? Now, since we've had COVID-19 for the last 2 years, the conclusion is that that is one of the major contributors to excess deaths. And so this graph, and you'll have it with you, is what has happened in South Africa. The MRC has looked at excess deaths. Now, just to explain, if you look at the lines, I'm going to make it a little bit big on the screen. We have 3 lines. The thick line is what is the predicted number of deaths. The dotted line above is what we call the upper limit, and the dotted line below is the lower limit. So there's always variation. We're never completely certain this is how many people should or shouldn't die. But if you look at it, I'm going to bring that up a little bit later. If you look at COVID-19 in South Africa across the waves, the excess deaths matches the COVID waves. And that's another reason we can say, if there's a surge in COVID cases and there's an increase in deaths, we can be reasonably confident, not 100%, but reasonably confident that many of these excess deaths, the majority, are due to COVID. And you can see it, wave 1, wave 2, wave 3, and wave 4. Importantly, the excess deaths in wave 4 decreased, both in the country and in the Western Cape. And critically, in this latest increase in cases, we haven't seen the excess deaths rise above the upper limit, both in the country and in the Western Cape. Fantastic news, right? The sad thing, though, colleagues, is that we've had 326,000 excess deaths in the country and 32,000 excess deaths in the Western Cape. So again, this ties into that first slide I showed you, that there are a lot of people who have passed away because of COVID-19. And I don't need to convince anyone. We all have family members relatives or friends. It has been a really tragic period across the world. All right, just to give you a little bit of a bonus, there isn't only COVID-19 going along. So I need to let you know about measles and I need to let you know about monkeypox, right? But so we have 4 confirmed cases in the Western Cape. Forget the fancy words. It does not meet I wrote they linked epidemiologically. We have 4 cases of measles. Sorry, these slides have been updated to give you the latest information. So I will give you the new slides, right? But I want to give you the hot of the press stuff. So 4 cases in the Western Cape. They are not linked, so it's not an outbreak, but we are very worried. We are very worried in the Western Cape, the country, and in the entire world because COVID-19 decreased vaccination rates. And so the potential for measles outbreaks, it's very high. And we get very concerned because it has a huge impact on children and even adults when we have measles outbreaks. Now, monkeypox. We are less concerned about monkeypox for a variety of reasons. And this is not a lecture on monkeypox, but monkeypox is spreading. 26,000 cases in the world that we've noted, and every day that number increases. We've seen it in 87 countries, right? And in South Africa, 3 cases, 1 in the Western Cape, we are never left out of anything, 1 in Gauteng and 1 in Limpopo. The cases are not linked and we've had no secondary cases from it. We're not overly concerned about monkeypox, but as with everything, we're keeping a close eye on it. All right. This was published. This is an article from this morning's Business Day, but the information came out yesterday. Brand new information. We've had the first confirmed death from a vaccine in South Africa, right? So the case has been investigated by SAPRA, which is the South African Health Products Regulation Authority. And what had happened was the individual was vaccinated. They developed something called Guillain-Barré syndrome, and they have passed away from the Guillain-Barré syndrome. The scientific community must report every information and all information, but we must be mindful about what this means. This is the first death noted in South Africa, recorded in South Africa, and to date, we have given 37 million vaccines. So it's the first death recorded with 37 million vaccines given. We also must be mindful that the excess deaths was over 300,000. So when looking at this, one must still understand that vaccines are one of the safest medications that we have available, and the benefit, the lives saved, far exceed the side effects and of course the deaths that may be caused by the vaccine. 1 out of 37 million doses. And I'll close off with this piece of research. So the Imperial College in London did a modeling study to try and understand how many lives were saved because of vaccines. Now, it's a complicated thing. They do excess deaths, and it's far beyond my level of understanding. But the estimate is that in the first year of the COVID-19 vaccination program, 19.8 million lives were saved. What that means is that there would have been another 19.8 million deaths, approximately, if there were not any vaccines. And this is also recent evidence that was published in 2022, just a few months ago. And with that, that concludes our presentation on an update on COVID-19. I hope the information has been useful. I've tried to give you the absolute latest information. You can go out there, wherever you go, to your family members mostly, and tell them you know what reproductive number is. Please do so. Now, honorable members, that was a lot. There's a second presentation. I'm happy to stop and take questions, or I can go into the second presentation. It is your choice.
Thank you so much, Doctor. I love your enthusiasm and the way you explain. Not all of us are doctors and experts on the subject, but you really made it very clear. Thank you so much for that. I have just one question for you. In terms of the low vaccination areas as until today, We had received data as the committee from the department. If you can perhaps just update us on that areas, whether it's still the same or we had an engagement in Mitchell's Plain the other day. We encouraged, obviously, members of the public to get vaccinated. Should we adjust our program accordingly and still continue with those outreaches to the community? That is my only question to you. And other members can pose their questions, and I think you answer them. And is it fine with you if we take a short break for 15 minutes then for coffee and come back to the other presentation? You have the time.
I do have the time, Honourable Member, and it's a lot of graphs and very heavy information. I think it's better to take the break and do that because it's, yeah, thank you.
Thanks for that fair warning. Member Windvogel, you have any questions on this presentation? Not on this one.
Not on this one. Yeah, but I do have, I thought you were saying we're taking a break. I just wanted to check with the monkeypox and is it measles?
Measles, yes.
Measles.
Measles, this is the Afrikaanse word.
Afrikaanse word,
Yeah.
yeah. So how dangerous is it? And is it the effect of COVID-19? Is there a connection between COVID and those other, this monkeypox? And then, Chair, with regards, but yeah, let me just stop.
Okay.
So, Honourable Member, let's talk.
Excuse me, Doctor. Anything from your side?
Yeah,
Plato?
Okay. Doc, good morning once again. Look, thanks for the presentation. Lots of information, valuable info. Also need to say thank you for the department sterling work done, preventing all these illnesses and that sort of thing. Two things. Listening to radio stations during the course of the week. As you know, many people, thousands, making use of radio stations. You drive into town, I think you yourself, and you log in, listen and that sort of thing. Radio Sonder Grense and Radio SAFM. I think it was yesterday or Wednesday morning. Still with medical practitioners speaking, worried about what they call a fifth wave that might hit South Africa during the month of September, middle September. When I get into my office, I immediately made a note of it because we were not pre-warned about a fifth wave coming. What they are saying, it will be similar like the Omicron variant. It might even be a little bit more severe than that. Now, it triggered some stuff in people's minds with regard to we're at the level where we can say we can nearly put COVID-19 behind us. But you hear things like that and you say to yourself, no, something is cooking. And we are not warned upfront about that, but that is what radio stations are there for. That is what scientists are there for. And the medical practitioner was of the opinion we must continue wearing a mask, specifically in a building. And secondly, they describe a building like where there's lots of people gathering like a church, like in a bigger meeting where there's many people in a meeting, but also a shopping center. And then they are saying even at big sporting events, it's advisable, according to them, that we must continue to wear a mask. And government have indicated it's not necessary to continue to wear masks. Now, I'm not saying medical people are playing themselves off against one another, but the public, we don't know what to believe. People phoning into the radio stations was of the opinion, we think with that information, we must still be very, very careful. What is your taking? What is the Department of Health's taking?
Thank you for that question.
Thank you very much, Member Plato. I recognize Member Barnes online, and then the last question from Member Windvogel. Member Barnes, you may proceed.
Thank you, Chair. Just one or two questions I'm having here. My first one is on measles. I think Doc, when he presented, he was saying that there might be a concern on the outbreak of measles. Perhaps I didn't see the slides. If one can just get maybe a feeling or elaboration on what the exact concern could be. And then my second question, Chair, would be where Doc was speaking on the severe drop in the province on testing. He made mention that it might be because people are not coming to test anymore. But would I be correct if I say, now I'm asking it in layman's term as a person that's not a medical practitioner, could it be that people are getting healed without the vaccination on their own? Is there such a possibility? Because many a times as community leaders, we are asked as to, are we forced to vaccine? Does it mean that now COVID is gone? How can I help myself without testing? Can one say that one can heal? I don't want you to confirm one can heal and then I spread out the word one can heal without testing, but I just want to check, is there such a possibility that one can heal from COVID-19 without testing, without having any medication? Yes, of course, we know the basics like paracetamol, we do those things, but can one just get clarity? How do we get to such a low stats and drops? Maybe a better explanation. I don't know. I'm not saying the explanation that you are giving is not good enough, but I just want to satisfy myself. My last question, Doc, would be on the death that is recorded because of vaccine. I know you might also not be in a position to answer me now, but when the vaccines were designed or made, was there no way during the testing, the scientists may perhaps, where they checked on the possibility that there might be a side effect of death? Because as a vaccine person myself, I can't remember when I went for testing being cautioned of you might die. The only thing that I know is that there are side effects, but never have there ever been a mention of there's a possibility of death. Maybe if I can get a professional input on that as well, it will assist. I thank you very much, Chair.
Thank you very much, Member Barnes. Member Van Vogel.
You, Chairperson. Chair, mine is I need clarity on the reproduction in terms of how do you measure? What did you use to measure that? You are a doctor. I'm not a doctor. You are the expert. So if you can explain it to me so that I can get that understanding. Then, Chairperson, the other question, I think Member Barnes touched on that, is with regards to this, to the confirmation by SAPRA, the death linked to COVID-19 vaccination.
Mm-hmm.
How will this impact on the vaccine roll out in the province? Or, yeah, let us focus on the province, and what programs are there to allay the fears of people? When you hear it, it's too much. I am not going to take it. Look, there's someone died. So yeah, if you can just from your side, so that people can hear. Doctor is saying it's okay, it's fine. So if I can just get that feeling. Thank you, Chair.
Thank you very much, Member Van Vogel. Dr. Moodley.
Sorry, Member Philander, can I please ask Member Barnes to repeat the question on measles?
Measles.
Sorry? Measles, yes.
Member Barnes.
Okay, Chair. On measles, my question was that when Doc was presenting earlier, he said there might be a concern on an outbreak of measles, but Doc did not elaborate. I'm not sure if it was stats that were shown on screen because I cannot see on this platform. If maybe I could just get a feeling on what Doc meant when he was speaking on the concern of, are there stats proving that, or if I can just get his feeling on what's really happening, how did he get to the point of making mention of that? Thank you, Chair.
Thank you very much, Member Barnes. Dr. Moodley, over to you.
Thank you. Thank you. And thank you, members, for these interesting questions. So let us start with which are the low vaccination areas in the Western Cape. So in the next presentation, you will look at the age groups that we are concerned about in terms of low vaccination. So in any area, you might have certain age groups, and I'll give you a preview. It's the younger groups that have lower vaccination rates than the older groups. In terms of geographic areas, consistently, we have been concerned about the areas of Mitchell's Plain, Khayelitsha, and the Central Karoo district in the rural section of the Western Cape. Those areas have slightly lower registration rates, and we use that as a proxy to say that they would have lower vaccination rates. So those are the areas that we're concerned about. If you look, we have a dashboard. I've quickly gone onto it. You can actually see it on the screen there. The Western Cape government has a dashboard that looks at registrations, and we look at percentage of individuals registered in geographic areas. And the areas that stand out, you can see, in addition to what I've said, Khayelitsha stands out. I would say Delft stands out. In addition to what I've already said, Khayelitsha, Delft, Blue Downs stands out. Matroosfontein, Macassar, Easter River, 18.8, Blackheath. So I'm actually going to lower geographic levels. Kayamandi, Crossroads. Okay. So those are some of the areas. The rest of them would be found in the dashboard, but that gives us an indication. But I think it's easier to look at it in larger geographic blocks. And the three areas that I've mentioned are of particular concern: Mitchell's Plain, Khayelitsha, and the Central Karoo region. Right. What can we talk about in terms of measles versus monkeypox? A little bit of information on that. Okay, so monkeypox does not have a high case fatality rate, and it does not spread as quickly as either measles or COVID-19. In fact, for monkeypox to spread, you need close, prolonged contact with someone who's got so the sign of monkeypox is what we call a vesicle, or a little boil, as people understand it. You need close and prolonged contact with the individual. So you actually need to be next to them. Whereas COVID-19, you can actually spread it in this distance, in a closed room. So monkeypox does not spread as quickly as COVID-19. And that is why, if you noticed, even though it was detected quite a long time ago, there's about less than 30,000 cases. So we're not overly concerned about it, but as with everything, we are mindful and we are vigilant. One of the other things about monkeypox is that people assume you have to have it over your entire body. It's not the case. You can have a handful of these blisters or boils, and that could be monkeypox. Right? Yeah, look, there's a lot more information, but I wouldn't be too concerned about monkeypox right now, but there are those three cases in South Africa. Measles is a different story entirely. Measles spreads very fast. In fact, it's one of the fastest spreading viruses. And the thing about measles, and I'm going to speak as a doctor now, I'm not going to give you statistics, but it's heartbreaking because it's often the children in the poorest communities that get, when there's an outbreak, it's the children in the poorest communities that get it. And they often have other factors that make things even worse. So maybe there's a nutrition issue, maybe they have another infection, and it is really devastating. Children do die from it. They can die from it. And they often have to be admitted and suffer very severe illness from it. So what happens, we talk about population level protection. In order for there not to be a measles outbreak, the population needs to be vaccinated. And if the population is vaccinated, then everyone is protected. But if individuals say, well, I don't feel like taking a vaccine, then the population level drops. And then people get measles, right? There's an outbreak. Now, if you have access to the best healthcare in the world, it should be okay. It can still be devastating, but it should be okay. But if you are poor and you have difficulty with basic things like paying for a taxi to get to a health service, then it's really difficult. And it's always the poorest people that suffer when there's a measles outbreak, and the poorest children that suffer when there's a measles outbreak. You can see how strongly healthcare professionals feel about measles, and we really get very concerned about it. Just to add, and this ties into what the other members said as well, why are we more worried about measles now than any other time? So the first thing is we are always worried about measles, right? But with COVID-19, all across the world, people started going to the doctor less. They went less to the doctor because they were scared to move, they were scared to travel, or there were lockdown measures. And you can see it in all our statistics. Western Cape, national, worldwide, the number of healthcare visits dropped. If healthcare visits dropped, one of the healthcare visits is for vaccinations. So the number of measles vaccines have dropped. And now the World Health Organization is worried about that, and understandably so. Sir, you asked me, Mr. Clark, you asked me a very interesting question. So the first thing is about, are we going to see another COVID wave? The answer is we've had multiple COVID waves after a certain period of time, right? So the first question you have to ask is, why do we get a COVID wave? There's a couple reasons for it. Three main reasons. Number one, we get a new variant. The new variant comes along, doesn't care about anything else, doesn't care that we've had in COVID before, and we get an increase in cases. The second is something called waning immunity. So there's two types of immunity. One of the immunities is caused by antibodies, right? And if you, depending on how you receive your immunity, those antibodies decrease over time. So if enough time passes, your antibodies decrease, increased chance of getting COVID-19. And then the third thing, which speaks to your question, is the measures we use to prevent getting COVID-19. And that is, if we wear masks, if we avoid crowded spaces, if we keep out of contact with people who are sick, then we decrease our chances of getting it. So the question that has come up is, South Africa has decreased regulations, right? We can see in this room, we're not wearing masks, right? There are no, if there's an event, there are no limitations anymore. You don't need to wear masks on aeroplanes. You can go to the movie theaters. There are no restrictions there. What does that mean? Well, the South African government has tried to balance how we respond to COVID-19. And they've taken a lot of factors into consideration. They've taken, and I'm going to talk about it now, the amount of exposure we've had to COVID-19 and our protection from COVID-19 into consideration. They've taken the decreased deaths that occurred in Omicron and the recent increase in cases into consideration, and the decrease compared to cases. And they've tried to strike a balance. We must also remember that when we put in all these measures, it affects other health services, it affects the economy, it affects the livelihood of people. How do you find the balance between the two? And the South African government has tried to do their best to do that. The dropping of regulations has been supported by many scientists in the field. I personally support the dropping of regulations as well as a healthcare professional. I'm not an expert in the field, but I'm knowledgeable in terms of my knowledge. I support it. But we're going to get to personal protection in a minute, right? There's two more things. And I'm sorry, because it seems like a lot of information to take into consideration. So this is not a decision we make easily, right? It was very carefully thought out. And the Premier of the Western Cape also called and agreed with the National Department of Health and the National Minister and the President that these regulations should drop. And you would have noticed that these regulations have dropped in other countries as well. So I'll give you one more piece of information. A study by the National Blood Transfusion Service showed that in South Africa, we had very high levels of protection, well in the upper 90s. There are more studies coming out that will likely confirm this. What does this mean? It means that most people have either been vaccinated or been infected or a combination of the two. And because of that, we have a degree of protection. The protection may be not that high against infection, but it is very high against severe illness and death. And so taking all of that into consideration, that's the decision that the government made. But I'll tell you one more thing. I wear a mask when I get onto an aeroplane. That is a personal decision that I have made, right? So I wear a mask, my daughter wears a mask, right? And I wear, I spoke to people. Someone told me she wears a mask when she gets into a taxi, right? I think the main thing now is that you must make sure you are personally protected. How do you personally protect yourself? Get vaccinated, wear a mask, right? Especially when you are in an indoor space and in a crowded space. Make good decisions for yourself. And if someone's wearing a mask, support them. You know, it's good. I don't mind seeing people wear masks. I quite like it. They're making a personal decision for themselves. So that's the answer. I hope I have answered you adequately. Yeah. Yes, we are. So there's a difference between mandatory, where it's the law to wear a mask, and where we give a person a choice to wear a mask. Yeah, and I'll leave that there. And Member Barnes asked me about measles, and I'm going to answer her question about measles. And then Member Barnes also asked me about the drop-in testing and about protection. So I think I've answered most of the questions about measles, but we are very worried about measles, Member Barnes, and it's about vaccination rates. So I think that's important. Now, you asked about whether can we heal by ourselves, right? And I must also remember you asked me the question about the death. So let's talk about healing by ourselves. So I think the way to understand it is, how do we get protection from COVID-19? And so there's two ways we get protection from COVID-19. The first is if you get vaccinated. If you get vaccinated and you get your vaccine, which is the 2 doses and then the booster, you have very high levels of protection. In the beginning, it was 94% against severe illness and death, and upper 80s, 88% against symptomatic infection. And that was huge. But then Omicron came about, and the protection against infection, dropped somewhat. But if you get vaccinated, you have very good protection against severe illness and death. And that's why the numbers have actually dropped. If you get infected, so I'm not going to ask, but I can share that some of my family members have tested positive, right? I know we all know family members that have tested positive. Many people have tested positive, and we're okay with sharing that information. If you get infected with COVID-19, you also develop a degree of protection. Just like with vaccines, in the beginning, you had great protection against getting sick again. Now, your protection is more against severe illness and death. The protection against just getting infected is not that high, but the protection against severe illness and death has been maintained. And remember, what is it that we always wanted? We wanted to turn COVID-19 into something that was as severe as the flu or less severe. And that's what's happening. If it's not going to put you in hospital or kill you, then it is something we can work with, and that's what we need to aim for. So, Member Barnes, what I would say to now we're getting into an interesting space. So we know that getting infected gives you a degree of protection, and getting vaccinated gives you a degree of protection. But what do you advise people? As a doctor, I do not advise people to get infected to go get their protection. So someone is coughing, hey, let me give you a hug and a kiss and I'm going to get protected. You know, technically, you could say it could give you protection, but the risks are so high. The risks are huge. So there's the risk of death, and there's a very high risk of long COVID. And it's not worth it, right? You'd rather get vaccinated where the risks are much lower. Now, here's an interesting thing. If you've tested positive and you've gotten infected, your vaccine, you have what we call hybrid immunity, the best immunity. So you are riding in the Ferrari of protection, right? Everyone else is driving a more sensible, vaccinated car, and so they're driving their Toyota, but you've got your Ferrari. So remember, I would not advise people to get infected for protection, but science shows that getting infected offers some degree of protection. Your best protection, member, is vaccination and being vaccinated. And if you've been infected and been vaccinated, hybrid immunity, that's top of the list. Right. So I knew that when we published the information on the death from the vaccine, that there would be questions about it. The first thing you must understand is you have to tell the truth, and you have to be transparent. You cannot tell the public, you cannot hide information from the public. So the minute we found out, we published it, right? Because people need to know. But again, I will say, measure it against the 37 million vaccines given in this country alone, and measure it against the number of lives we've saved. Everything we do in life has risk. Getting into the car today to drive to work has risk. You could be in an accident and you could die from it. Getting into an aeroplane has risk. Taking a Panado has risk, right? The vaccines are one of the safest medications ever created. And if you don't believe my words, I'm fully vaccinated and boosted, right? This is what healthcare professionals do. Trust the people who know the science the best. So that's my answer to you. But and to answer your question, the vaccines have been extensively tested, and we don't approve every vaccine that is created. SAPRA did not approve one of the vaccines that sought approval in South Africa, but they have approved the Pfizer vaccine, and they have approved the Johnson & Johnson vaccine. They go through rigorous trials, animal studies, people studies, safety studies, and that's the case for all medication. This side effect is exceedingly rare. And so it was not picked up. It did get picked up later, so we are aware of it in studies done in the United States, but it is exceedingly rare. Nothing in life is without risk, and this is unfortunately one of the risks, and it's sad, but please view it, member, in terms of the risk. For example, I'll give you one more way of looking at it. If I flip a coin, right, what will it land? Heads or tails, right? Most of you will say that. But statistically, it could land on its edge. Now, it's very unlikely that it will do that, right? And so we can't make decisions for our lives based on a coin landing on its edge. The vaccines are very safe. We do have to tell the truth. But this shows just how few deaths, one death out of 37 million doses. And lastly, member, you asked me a very heavy scientific question about reproductive rate. It is really working backwards, looking at the number of cases and the number of increasing cases. So we look at the way the cases are increasing and we work backwards. So if the cases are increasing exponentially, it means the reproductive rate is higher. And if they are going down, we do a backwards calculation to get that number. But I wouldn't worry about the heavy science, right? I promise you, if you go to your family and tell them the reproductive rate is below 1 at the moment, but it blipped when the children went back to school, possibly, they will be very impressed with that. I'm sure they'll live with that, but yes. And I think that answers all the questions. If there are any other questions, I'm happy to do my best to answer it.
It seems like in the committee room we covered. Member Barnes, online, are you covered on this presentation? Any follow-ups from you?
Covered, Chair, thank you.
Thank you so much, Member Barnes. We'll be taking a 15-minute break now. You can also have a break now. And then we will return for the second presentation. Members, please be on time. We'll be back at 10:20. Thank you. Member Barnes, are you with us? Okay. Okay. N- Not a problem. Thank you, members. We will then proceed with our committee engagement this morning. Dr. Moodley, over to you with regards to the second presentation, please.
Chairperson,
Yes,
can I
member.
perhaps ask if Doc can just elaborate on the death issue fatal before going into the
Sure.
presentation?
Not a problem.
Because people are sending me messages saying, please ask him to explain. If just few minutes of a minute or two.
Sure.
Honourable member, can I continue?
You may. Thank you,
So,
Doctor.
Thank you for the questions. Members always take advantage when you have a doctor answering questions. So I'll answer the question. So the individual received the vaccine. They received the Janssen vaccine. Remember, there are two vaccines that we receive in South Africa, the Janssen and the Pfizer vaccine. The illness that they developed is something called Guillain-Barré syndrome. It's very complicated to remember the name. We call it GBS. You can Google GBS and you'll find out a decent description of it. What Guillain-Barré syndrome is that it's a nerve problem. It affects the nerves in the body. Now, you can get Guillain-Barré syndrome after viral infections if you have a virus. And as you've noted now, you can get it following a vaccination. What happens in Guillain-Barré syndrome is that your nerves are affected and the conduction through your nerves slow down. So it's almost a form of progressive paralysis. You get weaker and weaker. The thing about Guillain-Barré syndrome is that it's self-limiting and you normalize after a while, maybe a few weeks, and then you're back to normal and you retain full functionality. The problem is whether there's a complication while you are getting that paralysis, and particularly if there's a complication where the paralysis spreads to your, what we call your rib muscles, and it affects your breathing. But that's what Guillain-Barré syndrome is essentially. There are many famous people who've actually developed Guillain-Barré syndrome and have recovered fully, but I'm not going to mention them. I'll leave you to Google them. Thank you.
Thank you very much. You covered, Member Van Vogel.
Thank you.
Thank you, Dr. Moodley. Dr. Moodley, how many people were affected by complications due to the vaccine in the Western Cape?
So I've got the number for the country, and I will have to go and get that data for you. So let me say that I will get that data and I will report back to the standing committee on that. Will that be okay?
Not a problem.
Okay.
In order. Thank you so much, Doctor. Then we can proceed with the second presentation, please.
Okay. Vaccines in the Western Cape. Okay, thank you, honourable members. We're now going to the second presentation. It's going to be a little less heavy and scientific, but it's about vaccine inputs. So what have we been doing in the Western Cape with regards to vaccinations? And the starting slide really tells you everything you need to, sorry, I'm just checking something here, everything you need to know. So up to the 3rd of August 2022, we have administered 5.5 million vaccines. That's a combination of first dose, second dose, boosters, etc. We have vaccinated almost 3 million individuals. We estimate that there's about 7 million people in the Western Cape, so we've vaccinated almost 3 million people. In terms of nationally, over 18, 46.45% of people have received a full primary series. When I say full primary series, I mean that they've received 2 doses of Pfizer or 1 dose of J&J. In the Western Cape, it's a little bit higher. It's 52.51%. That's full primary series. Now, when you break that number down, you see that it's different in different age groups. I'm going to give you the reason I think it's different, and I think it makes sense. Older people, because age is a clear factor in the impact of COVID-19 and how you will recover from COVID-19, older people have been choose to be more vaccinated or get their vaccines more than younger people. And let's look at the numbers. If you're over 60, 72.66% full primary series. 50 to 59, excuse me, sir? No, sir, not including the booster. This is full primary series, first dose and second dose, but not the booster. Thank you. If you're 50 to 59, 63%. If you're 34 to 49, 54%. If you're 18 to 34, 40%. What that means is that in 18 to 34s, 40% of people have received their full primary series, and 12 to 17, 8.22% full primary series vaccinated. We have to date administered 579,000 booster doses. So the percentage of people who've received their boosters is much lower than the numbers you're seeing there. Right. This is a complicated slide, but it gives you the information in more detail, including the percentage that have received boosters. But essentially, these 3 points are critical. The province has achieved the target of 70% in over 60 years, full primary series vaccinated. We've achieved our target that is set locally and by national. We need to focus on the 50 to 59 years to reach 70% coverage in that group. And concerted efforts are being made to take up increased vaccination uptake in the younger age groups, 18 to 34s, 35 to 49s, and 12 to 17s. Now, this graph is from the public national dashboard. And if you click on it, you actually get straight to the dashboard. And it looks at all provinces. The red is Gauteng, the purple is the Western Cape. But the key here is to see that in the early parts, July 2021, we were giving massive amounts of vaccines. If I recall, in this, was it nationally, or we could give hundreds of thousands of vaccines in a day. In a day, in this country, we could give 200,000 vaccines. That's an amazing feat. So it was never a question of, can we give a lot of vaccines? It's a question of, in my view, do people want to come in and get vaccinated? And not just the Western Cape, but the entire country. You can see this pattern. And so we had a huge, we gave a lot of vaccines around July to October 2021, and then it steadily dropped. And if you look at the bottom, you can see that across the country, the number of vaccines we're giving is very low at the moment. And we'll go to the numbers in a few seconds. This is the numbers. These are the numbers in the Western Cape from March to July. In the last week, just to give you, in March, we were giving about 60,000 vaccines per week, right? We could, at our peak, give over 50,000 vaccines in a day. In a day. Yes, correct, in a day. So now we're giving 60,000 in a week. In the last week, we gave 5,479 vaccines total. There's clearly a drop-off in the number of vaccines we can give. I wish to state, it is not a question of our ability to give a lot of vaccines, but a question of whether people are coming in to receive the vaccines. So, what is our vaccine rollout strategy? Number one, we want to integrate vaccines into routine care. And members, I do need to stress this. While a lot of our emphasis has been on COVID-19, we must not forget that people also have TB, HIV, cancers, surgical problems, and we need to make sure that we take care of those things as well. Across the world, there is clear evidence that there has been decreased service delivery because of COVID-19. We need to normalize this now. So we mustn't forget about COVID-19, but COVID-19 must be part of routine services. And that's our plan in the Western Cape and the plan in the rest of the country. But we also want people to understand that if they come to us, that they can easily get a vaccination, right? We need to make it easy. We want to move our focus to younger age bands, and so we'll be doing outreaches in a school-based vaccination program. So we know where the children are, where the young people are. Let's get them vaccinated in the schools, and we are working with the Department of Education with regards to that. Now, we are going to rationalize the number of sites we have for vaccines. And that's not because we don't want to decrease the service. We will keep the service exactly as it is, but it takes a lot of resources to keep these sites up. You do not want to have 200 people working in a site that's giving 5 vaccines. We want to rationalize, optimize, and maximize the efficiency. We also want to do geographic mapping of vaccine coverage. I showed you the areas so that we could do targeted outreach. Now, what does that mean? I'll show you a picture in terms of what targeted outreach means in a few seconds. We want to continue working with the private sector sites, including the pharmacies, so that the private sector can make sure people who choose to get their vaccinations in the private sector can make sure that they also can get their vaccines. And we want to develop strategies so that people want to get vaccines. We want people to be knowledgeable about the benefits and the risks of vaccines so that they can make good decisions for themselves. All right. So what are some of our victories and successes? We've given 5.5 million vaccinations. We've achieved our target in the over 60 group. 72% integration of vaccinations into our routine services. So we're bringing vaccinations into our routine services. We have many data products, dashboards, communique that we send out to the public so that we keep the communication going. And we have good partnerships with donors, partnerships with Western Cape government departments like the Education Department, Department of the Premier, Department of Economic Development and Tourism. We have good relationships with the private sector. We will continue with our communication campaigns to encourage uptake of vaccinations. Right? In terms of the integration of vaccines, you can look at the bottom, 72% integration. What that means is in 72% of our facilities, and this is mostly primary healthcare, if you go to the facility, you can get routine services and you can get a vaccination, right? You can get both, right? So if you come in for your diabetes medication and a checkup with your doctor, and the doctor says, ma'am or sir, have you been vaccinated? And you have a conversation about it, and you say, you know what, I want to get vaccinated, then you can just go across and get vaccinated. But we still have some vaccine-specific sites for those people who are only interested in vaccinations. So my daughter doesn't want to be examined, but she wants to go to get her vaccine, and we can make that available to her as well. This is an example of the dashboards that we develop so we can target where we want to go and vaccinate people. And then this is what I meant by targeted campaigns. We are very proud of the Vaccine Taxi. Not just because it sounds nice, but because it's such an important service. So what is the Vaccine Taxi? The Vaccine Taxi is when we put a taxi together and we set up a mobile vaccination site. So the taxi goes to a place and puts up a tent, and we can start giving vaccinations. Now, why is that important? Because that is what we call taking services to the people, to the community. It's sometimes difficult to get to a clinic. Now, we know our clinics are close, but it costs to take a taxi. It costs to take a day off work. It costs to walk to a primary healthcare facility. How wonderful and fulfilling it is and useful it is to our patients to take a taxi to them and vaccinate them. And of course, we're not targeting the places where it's easy for people to get services. We're not going to the center of town. We're going to the hard to reach places. We're going to the communities in Mitchell's Plain and Kaya Licha, in Mfuleni, in Kleinvlei, and in the far off rural places, so we make sure that they can get vaccinations. And I must say, we are very proud of this service. There's so much more we can say about it. Here you can see they're going to various sites. I don't know where this is, but as you can see, it's just such a joyous experience to go out and make services available. I wish we could do this for every single thing that we do. Right. In terms of our communication, you can see we've got a lot of very, I would say our communication is very high end. We have very targeted communication. We have very specific messages. Here you can see the message is about staying safe. Here you can see is I want to get vaccinated. It's a young person on the bottom right because they want to get back to their normal life. Here is a message that says stay safe by wearing a mask when indoors with others or in crowded spaces. Now, it's not legislated anymore, but we're still saying stay safe, right? And of course, we target our younger people as well. Here we talk about booster doses, tips to stay safe, and why a booster dose is important, including covering topics like waning immunity. We continue with our targeted campaigns so that we target all the necessary groups and we give people the information that they need to stay safe. But there are challenges. There's no doubt you've seen that the vaccination numbers have dropped. If you've ever walked past a site that does vaccination, you may have noticed that it might be empty or there might just be a few people, right? And that is our reality. In the Western Cape, in the country, across the world. The United States could give up to 4 million vaccines in a day. They are giving nowhere close to those numbers anymore. But that's because of what has been going on, because people have gotten vaccinated or they've gotten infected or they're less concerned. There's a number of factors. So our challenge, there's a consistent drop in uptake of primary series and booster vaccinations. People have COVID fatigue. You've heard the term? Like they're tired. They want to get back to life. They want to braai and they want to go to funerals, which is an important part of being a human being, going to a funeral, going to a wedding. And so they're less scared. There's a low uptake among younger age cohorts, and there's a lower than expected uptake of boosters across all age cohorts. So just a few remarks. The uptake of booster doses remains low. The province has achieved its target of over 70% of full primary series in the over 60s. We have ongoing communication campaigns. We continue with social mobilization, which means working with community organizations, churches, community members to encourage people to get vaccines. Every opportunity is an opportunity to inform people about vaccines and to encourage the uptake of vaccines. The current strategic focus is to integrate COVID vaccines into routine care. Vaccinations, and then the last two messages. Vaccinations remain our best form of protection against COVID-19, particularly against severe illness and death. And then I didn't finish it in the slide, but don't forget about long COVID. Long COVID is a very serious problem caused by COVID-19 infection. And for those of us that have family members with long COVID or who are presently experiencing long COVID, it is not pleasant. It can be very debilitating. Right, which brings us to the end. Sorry, that was a very loud right, where we have concluded our presentation, and we now go to the Ask a Doctor Standing Committee edition. Now, if you didn't know, there was a program we had where we had doctors going out to Mitchell's Plain Mall, and they could ask the doctor any question about COVID-19, right? And people like that, right? Mostly because it was a free consult, but also it's a good opportunity to communicate. And I now offer that for the standing committee. Thank you, and I'll stop there.
Thank you so much, Dr. Moodley, for your most informative presentation to us. I'm definitely covered by your targeted approach in terms of the young people. Thank you for alluding us to that in terms of the programs that you will be running with schools and the Department of Education. So I'm covered in that instance. Member Winvogel, are there anything from your side? Yeah.
Mine is on the criteria. I want to understand what the criteria is followed to allocate these vaccine sites in the different communities. What criteria was followed? If you look at Kylie, which is plain. Yeah. Because I saw there's 10 and 9, I think 10 and 9. So what criteria was used to allocate those vaccine sites? Thanks, Jane.
Thank you, Member Winvogel. Honorable Plato.
I think presentation was very informative. I think the doctor answered. I made 3 points. Similar to Member Van Vogel, the younger generation with their low uptake of vaccinations is a big worry. I'm very happy to hear about the vaccine taxi. I think it's a very good one to take the services to the public out there. But the younger generation, I think we still need to do a little bit more regarding that. I don't know what. And then the older generation, the issue with regard to the low uptake for the boosters is a big worry for me. And school-based vaccination seems to me also on a low side. And maybe we need to pay more attention to those issues. Thank you.
Thank you very much, Honorable Plato. And I think perhaps also with the young people, to get onto their level, the young ones speak to the young ones. Perhaps they're not interested in what the older people has to say or the information that's conveyed by, but perhaps also your communication strategy perhaps also needs some adjustments, but you are definitely on top of it, and I'm sure you'll address that in due course as well. Dr. Moodley, I think that covers our questions with Member Barnes that tendered an apology. Do you have a last question, Member Van Vogel?
Yeah. The department themselves.
Thank you, Member. Dr. Moodley?
So, honourable members, thank you for the questions and comments. I'll just start with the comments from the honourable member about concerns about boosters and young people. We are in full agreement. We wish everyone got their booster. Remember, if you're over 50, you can get a second booster. And we definitely encourage people to take their boosters. Again, I'm going to use my personal example. I am boosted and I took the first opportunity to get my booster. It's really about keeping yourself safe. Yeah. And if you have older family members, it's about keeping them safe as well. We've all lost from COVID-19. Right. Honourable member, you asked about how we decide the remaining integration and allocation. Initially, it was about getting everyone vaccinated. And the truth is, if we could still keep the numbers up and hit very high levels, we would keep many more sites open. But what we've realized with the dwindling numbers is that we need to be strategic about where we put our resources. So it is a combination. We look at the data about where vaccination uptake is the lowest and the highest. And there's no doubt Khayelitsha, Mitchell's Plain in the metro stand out, Central Karoo stands out in the rural. There's a few other areas as well. So we would increase resources to that particular place. In particular, we've been aware of Khayelitsha and Mitchell's Plain being problematic. I wouldn't say problematic areas of low uptake. And so there has been many more examples of outreach in those areas than areas where there would be higher uptake. And that would mean more visits by the Vaxi Taxi and more visits by outreach teams that would set up vaccination, we call it outreach sites, next to the shopping malls, so that we could get people vaccinated. If I recall correctly, there's a Pick and Pay in Khayelitsha in that central business district. It's either Pick and Pay or a Spar, and we'd set up a vaccination site there, and we got quite good numbers. But it is a combination of factors. But we're very mindful of one thing. We're very mindful of equity, and we're very mindful of the poorest areas and the difficulty people in those areas have to get vaccinated, and we make our effort to go to those areas as well. One more thing we do is that we work with community organizations, especially religious groups, but other community organizations, and we work in partnership so that we can increase demand. And so if a pastor or a imam speaks to their congregation and encourages vaccinations, that demand is created and we go straight in. The issue, and you'll hear me say a lot in the Western Cape, but in the rest of the country as well, is demand. We can vaccinate a lot of people. We learned that we are very good at it, but it's about creating demand. If we get people that want to be vaccinated, we can get them, and it doesn't matter where you live. We'll come to you and vaccinate you.
Covered members?
Taxi. And it's more in the metro and not in the rural areas. How do you, but I'm thinking now about the Karoo. I never saw a maxi taxi in my area where I come from. Area. So I'm thinking of what is the plan with the Karoo, because remember, they are widespread as long as to get the small towns far from the Beaufort areas. If I can put it like that.
So, Honourable Member, may I?
Yes,
Sorry.
please
Honourable
do.
Member, we have multiple strategies to increase vaccination uptake in the Karoo, including making multiple sites at strategic locations available. So we are aware of the long distances between towns. But I want to give you a precise answer because it sounds like you want a vaccine taxi in the Central Karoo. So I do have to get back to Honourable Member Philander about one of the questions. I will contact my colleagues in EMS to find out if there are vaccine taxi plans in the Central Karoo and what they are, and I'll feed back to you, but also what other plans there are for vaccination sites in the Central Karoo. I don't want to guess that information at this meet.
Thank you very much, members. Thank you very much, Dr. Moodley. The department was also most accommodative during our outreach to Mitchell's Plain, where they made the service available. So according to our program and the information shared with us this morning, one of the sites that we are definitely considering is that of the Central Karoo. So we will then also be submitting a formal request to the department in that regard, but we still need to get concurrence from the programming authority in terms of our date for that outreach as the committee. So I think, members, from our side, we can conclude our business for the day. Not exactly, but I think we still have some committee business that we need to take care of. But at this point, Dr. Moodley, thank you so much for coming to the committee this morning. We've really enjoyed your presentations. It has been most informative. And us, not being health professionals in that matter really could understand, and I'm sure those that were also online could have done the same. So we look forward to inviting you to our committee next time, and perhaps also having you with us at one of our outreaches in the community. So thank you so much, and all the best to you with your wonderful work that you're doing in the department. Keep well. Thank you.
It's all good. Thank you, honourable members. Thank you for the hard work you guys do. We all in it to help people, and it's a pleasure to be here. Thank you so much,
sir. Keep well.
Lunch is available now. I saw the guys.
Monday.
Members? Yes, any resolutions, recommendations, doctor will provide us with the vaccine taxi information. Doctor will always also provide us with the number of complications due to the vaccine in the Western Cape.
Yes.
Any other further resolutions, recommendations? Covered? Thank you, members. That deals with recommendations and resolutions. We have any minutes?
No minutes.
No minutes?
Done. Just a meeting of next week.
Yes, next week meeting, the 12th of August, members. We will then again convene with the department that will brief us on the name change to the Department of Health and Wellness, as well as the department and integration of the City of Cape Town clinics to the Department of Health and Wellness, and this would be a virtual meeting. Honorable Van Vogel?
Chairperson, I'm not sure, but I have a bit of a problem if it comes to that topic that we have a virtual meeting, because not all of our people do have access, and we want the story to be spread.
Mm.
And I thought perhaps because there's a health, what is the name? The Maris. And because I went and visited them, if we can get those two, because we need them to spread the word in the community. So we need to be proactive and not wait for problems to occur. But sometimes when people don't know the information, that becomes dangerous. The Department of Government have good intentions, but we are not communicating it. En ek sê altyd een wat oningelig is eintlik gevaarlik. Maar as jy die ou inlig, dan weet jy okay, dis what is going to happen. So I'm asking the possibility if we can really look at like we done today in-person meeting. It's just a request from my side. Thanks, Chair.
Okay. Thank you very much, Member Van Vogel. Our purest intention of having the meeting in person, and we do find members that still log on online. So I don't want to be prescriptive. I hear what you're saying, but if some of us are in chambers or in the committee room, there will still might be members that's online. It doesn't seem like we will have a strict in-person meeting. Perhaps if someone should ask for the link. And as you said, I know data is an issue. It's very expensive for some of our community members, and we want the information to flow. Honorable Plato, what is your take on it?
Look, too much. The way
Mm.
and after this, I with I agree. The public need to be at the moment. One way I was saying adverts in the newspapers, but maybe the committee needing getting all the health forums, executives maybe together, maybe one or two reps per area, and officially inform them about it. I think that would be the right thing from us.
I just need clarity on your letter comment, Honorable Plato. Do you say that you would think that's a competency of the department and not necessarily the committee?
See,
Mm.
exactly likewise what you have done with the issue that we take with the officials, the officials from the city. Maybe region to region. Inform them about it. It's a big issue. It's not a Mickey Mouse issue. It's big. I think I still remember the integration with the ambulance service from municipalities. That was equally very good. Even today, many people are saying should not happen. There was a drop in service delivery to some extent. I don't know what the thinking will be with this one. But we can brace ourselves to receive a little back. But regardless if we're going to receive a little bit of money, it's our duty to speed information issues.
Yeah, let's do the best that we can. Members, my ruling then accordingly will be, then we will conduct an in-person meeting.
So next week is in person.
Next week is in person on Monday. I know that's your heart's desire as well.
But it's short notice for my catering.
Yes.
So if there's no catering, members, so you'll have to bear with me.
No, but we
I
all,
will try to
Yeah.
secure.
irrespective of, I think we conduct our business in the best interest of the public. And if that's so, I know it is a huge issue, and we need to inform the public. So, Member Van Vogel, we will have our meeting in person. And can I ask Namonde that perhaps to assist you as well, that you reach out to public education and outreach for them also to amplify the message that we will have this briefing to make sure that we have as many people present as we possibly can. Please. Member Van Vogel,
For
Yes,
the
so-
meeting of the 12th.
for the meeting of the 12th.
Thank you so much, Chair. I'm not sure, but can I send in another request in terms of EMS services? I'm not sure our program, because I missed out on the program. It was discussed last week
Yes.
in the meeting.
Can I ask you, Member Van Vogel, that please peruse the latest version of the program, and then you can email your suggestions to both myself and Amonde, and we see how best we can fit it in the program. I know there will also be a request coming from the Northwest Legislature to the committee. I've advised them this morning to put it in writing. They want to come to the Western Cape.
Okay.
But we'll also need to see how best we can fit that in the program as well. Members, thank you very much. That concludes our meeting. Thank you to our wonderful procedural support. You all must have a wonderful and a blessed weekend. Please be safe. Our meeting is now adjourned.
Thank you. And